All right, we're back. We're back on the record here. Time to start. All right. Yeah, I'm not that sick. As soon as this is over, I'm on the way home. Very happy. Man, you beat Barcelona yesterday 2-1. So they advanced. I'm very happy with that. See how they do. Got a cup final this weekend. We shall see. Ever so briefly, because I'm going to reinforce this in because I want to just. It's a brief conclusion, but I'm going to go over it again on Monday. We have the blood lab, and I have like it probably will take about an hour and a half or so to do the blood lab together, and I'll make sure everything is available. But we'll meet in the zoo lab at Monday our usual time, and go from there. Everything is voluntary. If you want to check your blood type,
You gonna prick your finger?
no, you're going to prick your finger.
What if I find out I was like switched up?
Yeah.
It's you're how would you know?
I know, like I feel like something like that would happen.
I don't even get, what's the big deal? It's
What do you mean? What's the big deal? I found out I was switched at birth.
I have 3 children that are switched at birth.
Yeah, but you knew that.
That's okay.
I'd be living
Hey,
a
look,
lie.
if they're not happy with you, then they have a problem.
That's what I'm saying.
Right? Hey, look, pays your money and you take your look. I always thought it was the stork.
Yeah, but I could like sue. I could make so much money.
Yeah,
We should probably just say I was switched at birth.
it's like the old joke. This lady,
Yeah, I'm like,
my
brother's university.
had 10 kids. Her husband was at the zoo throwing stones at the stork. After the 11th kid, the stork was throwing stones at him.
The good thing is though, if I get like shot.
That's from the same vintage of shooting an elephant in your pajamas.
Never heard that one.
Ah, the very famous Captain Spaulding in Animal Crackers, 1931. I got up in the morning and I shot an elephant in my pajamas. How he got in my pajamas, I'll never know.
If I was shot, first thing is, hey dog, get my brother here.
You didn't catch the punchline. How he got in my pajamas, telling you I shot an elephant in my pajamas. How he got in my pajamas, I'll never know. Elephant, they're big. You know how you can tell you can tell if an elephant's in the bathtub with you? Peanuts on his breath, you can smell them. What happens when you mix an elephant with peanut butter? You get peanut butter that never forgets, or an elephant that sticks to the roof of your mouth. These are old. Those were the jokes that we told before you could gratuitously swear or use sexual entendre at all times. Sir.
You know how you kill a blue elephant?
Say again?
You know how you kill a blue elephant?
How?
With a blue elephant.
Well, of course. I should have known that. I'm just saying goodbye. All right. Very briefly, because I'm going to go over this again. This is I don't do this. It's interesting. Some of my students do. Some of the A&P instructors are doing this. I call them antigens because that's what they are. Antigen in the old days came from the term antibody generating. So those are the markers that are obviously, as we all know, the protein carbohydrate markers that protrude from our cells. It's worth knowing, depending on where you're going in the future, if you see the term, and nowadays we have self and non-self antigens. So it's not necessarily anything perceived as foreign that can generate an immune response. Those to me would be non-self or foreign antigens. So red blood cell antigens specifically are called agglutinogens because, as you will see, or you may have seen in immunology, but when we do the immuno unit, one of the ways that antibodies and antigens react is by agglutination. And that's the whole idea of the typical blood grouping test that we do. We look for little speckles, which are agglutinated red blood cells. Basically what it is, okay? Because they promote agglutination. So Mismatched transfused blood is perceived as foreign and may be agglutinated and then destroyed. And so that is the big problem with mismatched transfusions, specifically when they're very, very vigorous. When you get A and B combined together, for instance, would be an example, and it's not the only example. And what happens, all those agglutinations, effectively you develop these large complex protein complexes, to use the same term twice. And what they do is they jam your kidney. Okay, and so usually there is the approach to dealing with a transfusion reaction certainly involves certain steps to deal with the potential for even short, period of time on dialysis if you can get to the patient soon enough. So we have a lot of markers. We're only going to do the standard ABO markers, but when you do even weak agglutinogens, when you're talking about organ transplantation, is very significant. So when they're doing tissue typing, let's say in the university has a child, that needs a kidney transplant, and they reach out and say, "Is anybody interested?" Okay. Basically what they do is they do typing, tissue typing, and they screen you. Let's say there's 100, I don't know, antigens. If you have 75 similar antigens, you would be considered a good match, arbitrarily. Whatever the number is, you need a fairly substantial percentage. And that's how not the fact that you might be a biological sibling, even though it's more likely to be a match, does not ensure that you're a match or being biologically related. It does not. So that's something else people don't understand. So the ABO and RH blood groups are the most vigorous reactions. Yes, sir.
Would identical twins have the exact same antibody?
They should. There are. It's called a chimera. It is. I don't know. Maybe you talked about it in genetics. Okay, where theoretically you could have during the gestation or fertilization, there could be an inaccuracy where they could have one segment that's but I think that's extraordinarily rare. So the answer would be yes. And indeed, when we get into immunology, that's effectively most of the transplants that we have are called allografts, meaning we're using from the same species. And an autograft would be from yourself, like you're donating blood for yourself. An isograft would be from an identical twin. So if you have an identical twin, do you have an identical twin? Oh, hey, can't win. So let's see what else. And then the other one, and we use these a lot, are called xenografts, which means from a different species. I mean, they've been using, and certain species are more graftable than others, like porcine, like pig-based, or no, it's not kosher, but pig-based. That was a joke, everybody.
Wait, Dr. So like, I think my brother's O negative, or like he's a universal donor or something.
Right.
I don't think I am. I think I'm like A, like how whatever my parents.
Yeah,
would his blood be better for me?
I do not know. I mean, short answer, theoretically, this O-neg is universal donor.
Yeah.
I mean, could you have that would be a question of the blood bank.
Okay.
Again, what they do blood bank wise is they typically don't do directed donations. They basically they'll take his O-neg and that'll supplement if you would need a transfusion.
Gotcha.
That's typically the way that works.
Because I didn't know. So I don't know. I was just thinking that would probably be similar genetics.
Yeah, you would think, but I don't know that that's, and I have no personal knowledge of it. So as everybody we'll go over it again, but you all know that this is considered multiple alleles because you have not just a dominant recessive, you have two dominants, which are the A and the B allele, and you have the recessive, which effectively is the recessive, and when we have two of them, it becomes the O. And so it's all a matter of, and understand, immunologically speaking, it's about the antigens, or in this case, the agglutinogens. They provoke the most aggressive responses. If you have unmatched antibodies, there will be a response. And it's something that we do see in certain kinds of blood. A number of babies have to undergo ultraviolet irradiation, like my middle one was like that because he had a certain degree of jaundice. That is probably more likely due to incompatible antibodies from the mom to the baby as opposed to incompatible blood that was there. And so it's different than something we'll look at very shortly, the erythroblastosis fetalis that's there. So, and what they do because of that hemolytic phenomena, those antibodies destroying the red cells, it produces an unusually large amount of bilirubin, and they deal with that with ultraviolet light. My middle one, interesting, because he was born, as far as we know, somewhere between 2 and 4 weeks premature. Being adopted, you don't get you don't get the whole picture. Okay, we know he was in pediatric intensive care. Part of it was because, not so much because of that, both of my younger 2 kids, I'm not telling tales out of school, I tell it everybody, were born of polyaddicted birth moms, or in his case, birth parents. And so that produced a lot of some very, very significant challenges early on. So that's why we were able to adopt 3 children in a relatively short period of time. In like 3 years and 2 weeks, because 2 of them were classified as special needs. And not everybody's willing to take special needs children. And they've only produced craziness in me. I was totally sane before the children. It's okay. You knew my younger 2 children. And the other one just orders me around all the time. But that's what he does for a living. He gives orders. All I can remember is walking in the ship. You go through one of those hatches, and you not only have to close the door, you have to swing, do the thing shut, so it's watertight. And he's, dog that! You go through a hatch, you dog it. It's like, okay, I'm your dad. You can dog it for me. No, this ship, dog your own hatch. The moral of this story.
You blew up any balloons yet?
What?
You blew up any balloons yet?
For him?
Yeah, over in the Mediterranean.
No, I have not. He has not blown up a balloon. I'm sure he's disappointed. They all want to shoot stuff down, particularly like space junk. Everybody wanted to shoot down the space junk because they have toys in there that oh god, from a long way away you can shoot the eyes out of a target. So the antibodies are called agglutinins, even though I call them antibodies for test-taking purposes, and they act against it. And so, as you can see, the anti-A or anti-B forms in the blood so the moral of the story is we are pre-programmed. Antibodies don't come entirely from exposure to an antigen or to a foreign substance. We are pre-programmed. There's a lot of genetic antibody pre-programming. Some of that accounts for what we heard a lot about during COVID called herd immunity. There's a certain amount of pre-programming that goes on. Okay. And as you can see, the adult levels are reached later on. The classic illustration, I'll show you that again. You can see there's some, I don't know that they're significant. There's some noteworthy changes population-wise where we see a greater predominance, particularly of B, in folks of color, of Asian, Hispanic, and Caucasian white. Some changes, Native American, you have a lot of predominance. What accounts for that, I don't know. What's interesting to me is that what predominates is the one that is effectively the double recessive. And why, and I don't have an understanding, maybe I should look at some scholarly articles of why having something it's not a universal recipient, so that's a more favored. Why would having a universal donor or something that's similar to that be more likely to be there? I don't know. So it's a short answer, I don't know. So you can see a variety of other ones. Understand that since it's standard Mendelian genetics, dominant recessive. So if you have a hybrid cross, you get 3 to 1. Okay, everybody knows that because you've all had every basic Punnett square. Yet, because you are more likely to have people who are both positive are more likely to marry, it increases the statistically. So typically when we see genetics, they are in that 80 to 85 to 1 category for Rh positive. And these are different, unlike A and B, where A antigens make B antibodies like I do, or B antigens make A antibody for something like with B blood. RH only works on exposure. That's the basis of erythroblastosis fetalis, the hemolytic disease of the newborn. And it's very, very specific because they're not spontaneously formed. There's no, the fact that the marker is there doesn't impact you. Okay. If you are RH negative, and particularly if a woman is RH negative and conceives an RH positive baby, however conception occurs, whether it's in vitro or biologically so, at the time that pregnancy ends, however it might end, doesn't have to be by birth. It could be a miscarriage or an induced abortion, whatever. Without getting into the context of all of those kinds of things, the reality is at that point, the baby's RH positive blood is going to come in contact with the mother's non-RH positive blood, and there's going to be the production of antibodies. So much so, and so vigorously so, that a second exposure can be of significant harm because antibodies cross the placental barrier. And so as that baby is undergoing gestation, the second positive, if it's two RH negative mom and dad, let's say, typically nothing to worry about. Okay. But if it's an RH positive dad who's homozygous positive, every conceivable, pregnancy would be that way. Conceivable pregnancy, that's it's like duplicating terms. It's a false pregnancy. It's laboring under a misconception. It's an old joke. Not a good joke. So here it is, erythroblastosis fetalis. First pregnancy, the exposure during delivery, or however the pregnancy ends, is a better way to say it, I believe. Make the RH antibodies. The second babies, they cross the placental barrier. There's a variety of ways. RhoGAM with the anti-RH has been around for a long time. Thankfully, this is a well-recognized phenomenon. So any degree of prenatal care will be aware of this. There's a misconception with regard to, and I had that in one of my classes, more than 10 or 12 years ago. This gal worked in Fox Chapel. My kids went to Fox Chapel. And I said, nobody doesn't have any intervention. Everybody sees a doctor when they're pregnant. No, they don't. Okay. I mean, maybe in Fox Chapel, I'll bet they do, but nowhere else. We saw so many of these in the inner city in Philadelphia when I was a resident, where, kids who gained a lot of weight because they didn't want to tell their mom and dad, little, girls, that they were pregnant. They came in crowning into the emergency room. We're dealing with a impoverished, to be kind, population, a difficult area of the inner city, to be fair. So all of that aside, and there's a lot of things, herpetic infections, genital urinary infections, will have significant impact on the health immediately after the delivery of the unborn child. We'll get into that as well. So mismatched blood, donor cells attacked, agglutinate, clogged vessels, rupture, hemoglobin into the bloodstream, blah, blah, blah. Hemoglobin in the kidney tubules is something that generates renal failure. It's a big problem. Okay. First sign, fever. Remember, I had a lot of transfusions. Basically, they send you home and say, take your temperature every hour. Call us immediately if there's a significant change, if there's any degree of a spike. I was lucky. I never had a transfusion reaction that were there because that's the start of it. Immediately, it's pyrogenic in nature. Chills because you're starting to lyse blood, and so your amount of red blood cells goes away, blood pressure, all the typical shock signs. So again, fluids, diuretic. Again, universal donor, more classically O negative because of the absence of the RH positive, and the universal recipient would be AB positive. And again, these are the auto transfusion or autologous transfusions. So when you blood type, you're looking specifically what we would do when you're cross-matching. Now we're looking for somebody who can be a compatible match for transfused blood. And again, every time, like I did, when you get a transfusion, you generate, because it's not your blood, you're going to generate antibodies. Doesn't matter how good the match is. Okay, I never got any, all my blood was blood bank blood that I got. And every time the cross match takes longer, it's harder to find. So, and this is what we see classically. I always see A is very clear, B is a lot more difficult to tell. Okay, so you have three of these basically that go on. You have three little spots where you put a drop of blood. Many of you may have done this already. You have three little drops that you put on the card. You add the reagent. The cards, I like to add the reagent rather than use the cards that have the pre-reagent. And then you take a toothpick, but a different one for each of these, combine the liquids together and see if they clump. Give them about 30 seconds, swirl them back and forth. And so, you can begin to see, it does not agglutinate. So in either way, and when we see the positive, then you'll definitely see it come together. It doesn't really agglutinate classically like speckles like this, but it does come together, I find. And all of these types of things, you saw all the blood tests, we use them constantly, etc. And we're going to do the differential account. What I showed you before was a CMP, or we call BMP now, basic metabolic panel, indicating the different kinds of damages, etc. That's all. Good. Done. We did the next unit already. I'm going to spend a very little amount of time on it. So that was the chapter 19. This is the introduction to immune. None of this is on you got the exam thing yesterday?
I saw it, yeah.
And yes, I'll go over it again on Wednesday in class. Just don't have to thank me. None of you are smiling at me. Oh, you're thank you. Closest thing I've ever seen to a smile this morning. Okay. Lymph. We did blood vessels anatomically. This to me is more of an anatomical system than a physiological system. Why I don't do it here, I want you to review it. Lymphatics are open-ended channels that are open in the tissue and pick up heavier, fatty-laden, microbiological entity fluids in the tissues with the ability to carry them because they're a little more forgiving than capillaries and things don't get clogged, and carry them eventually to rejoin the bloodstream at large vessels like the vena cava. Okay? So the beauty of the lymphatic vessels, the good news is they can carry these particles, and then once they're in larger vessels, eventually they'll make their way to the liver to be processed and dealt with. Along the way, they go through a series of filters we call lymph nodes. We see clusters of these lymph nodes at certain areas that are very much areas where are almost like guarding against areas where we're likely to get a lot of exposure. Extremities, whether it's fingers or toes. So you'll see a large accumulation, sometimes behind the knee, but mostly in the groin. We have a tremendous amount of those. In the axilla, sometimes in the elbow, but also in the axilla. You'll see a tremendous amount abdominally. So, and these nodes, which the universal thing anatomically is they have multiple inputs and minimal outputs. And what effectively, it's like a funnel. And it effectively sifts or funnels through the lymphatic material. And if it contains microorganisms, impurities, cancer cells, etc., that's where we start to deal with them. When sometimes they'll become enlarged with the reaction. And in other times, they will become infected themselves and even be a source of infection. We see they don't always have to be associated with lymphatic vessels, with lymphatic capillaries or lymph vessels. Sometimes they are openings where we have entry points or exit points, particularly, let's say, the mouth and the throat and the nose. So there you have small areas that have clefts. You have accumulation of lymph nodes. We call them tonsils or adenoids. And they have little clefts that are able to pick up materials that come in, and they too get infected all the time. We know they're in the GI tract. We have a giant cluster of it called the appendix, even though mostly it has that function, but mostly we think nowadays what it does is it reseeds the bowel with bacteria after, let's say, a bout with colitis or diarrhea. So that's kind of what we're looking at. So I wanted to review that with you, this idea of lymphatics, the fact that the fluid we classically call lymph, and we're just generally wherever there's a vein, there's a lymph vessel. So they're intimately associated with them and they play an important role. When you see, it's scary. I can remember seeing one as a kid with one of my buddies. When you see a red line going up their arm, it's called lymphangitis. Moms and dads called it blood poisoning. It was a misnomer because it wasn't in the bloodstream. It was an inflamed lymph node. The kid had it going up his elbow. He became a very famous physician. One of the smartest guys in the world I went to school with. I had an unusual class in my particular grade where I barely cracked the top 10 for smart. It's true. Of course, I would not use fooled around. I used different F word a lot during my high school years. But we had four people go to Harvard Law. He went to Harvard Medical School. You get the idea. The doctor who was murdered here at Tree of Life went to University of Pennsylvania Medical School. I wasn't in their league.
We're in a league of your own.
I was in a league of my own. The All-American Women's Baseball League. Great movie. Remember, there is no crying in baseball. That's a great movie. Okay. So, provides structural basis of the immune system. So the immune system doesn't have a lot of structure to it. It has a lot of physiological elements. This is the limited anatomy. So the lymph organs and tissues house those phagocytic cells and the cells that interact and develop what we will look at as the immunological response. So in addition to the vessels, we have spleen, thymus, tonsils, and obviously the thymus is an endocrine structure as well. Tonsils, lymph nodes, and other kinds of lymphoid tissue. You can see there's a rather substantial amount of fluid and it can get clogged. And anatomically with infection, certain kind, the most famous of these is a protozoan infection called elephantiasis, where a particular protozoan clogs the lymphatics and the fluid can't return from the leg and becomes like an elephant's leg because the fluid just has no way back, for instance. And you'll see that, and you can find an image of that anytime. One-way system because just like veins, they have valves. Okay, they're not the same kind of a valve, but they ensure one-way flow. So they're blind-ended or open-ended vessels in the tissues. Certain areas we don't have them in bone marrow, bones, teeth, not a big deal for us. Limited location in the meningeal area, okay. Similar to blood, more permeable, larger molecules that capillaries can't handle. Protein, cellular debris, pathogens, cancer cells. Okay, and this is free. It's not the only route for cancer cells or pathogens. They can easily be bloodborne. It's not the only route that they can get there. If you want to think of a famous sexually transmitted disease like syphilis, bloodborne. If you want to think of another disease like Lyme disease, very, very common today, bloodborne. Classic illustration, you can see the intimate association with capillary beds, and you see the nodes with the multiple inputs and limited outputs. So to me, it's just a series of funnels that we sift this through. They call them mini valves, that's fine. And mini valves are anchored, open, the volume opens them, when the volume diminishes, they close. You remember anatomically, and we're going to look at it again when we get to digestive, the lacteal. That's that famous individual lymph structure that's surrounded by a capillary bed that's in all those villi, those finger-like structures that are in, that they're so vital to understand vis-a-vis how digestion is enhancing surface area. Classically, lymph is referred to as chyle, C-H-Y-L-E. it got a different name for lymphatics than processed food, which was called chyme. So they used to talk about chyme and chyle together. They're the little flaps, collecting vessels, thinner walls, more valves, and it works its way up to the series. This is anatomy, I'm not going to do it. All these large trunks. Effectively, the right side of the upper arm, head, and neck drain through one common structure, the right lymphatic duct, into the superior vena cava. The thoracic duct drains everything else. Even from the abdomen, that's where you hear about the cisterna chyli, is there. Each lymph empties into venous circulation at the junction of the internal jugular and subclavian veins on its own side. So the thoracic duct is left-sided, the right lymphatic duct is right-sided. Those junctions are the brachiocephalic veins, and those combine together to form the superior vena cava. And again, that's anatomical, not physiological. Here you are. This is where they're located. Voila. So this is the neat thing. This is all the right, everything else, all the lower extremity. You see the clusters in the groin. So in medicine, when we see an infection in the knee, you go up and palpate in the groin to see if there's evidence of it spreading. If there's, it's like your mom did when you were sick. Just checking your throat for swollen glands. I think my mom was trying to. So my parents they didn't strain, they just smacked. They never got that memo. You bet you not can't hit your kids. My kids, 1-800 for a child. I fix them. You know what I do? Elder abuse. They come, elder abuse. Oh, help.
They'll put you in a one-star nursing home. I always tell my parents that.
Because they always did 1-800 for a child. Yeah. Imagine what they had to put up with me growing up with me. So you can see all these nodes. Famously, look at the axillary area. We know that's a major structural area from all the abundance of glandular tissue in the breast. And that's why if you're looking at potential breast cancer doing a breast biopsy, you're always doing a lymph node biopsy in the axilla. This is the blood poisoning, the lymphangitis. It works the same way as veins do. Skeletal muscle, pressure changes, valves, arteries pulsating, ta-da. This is what I was talking about, lymphedema. So when edema that's fluid-based, when it's liquid edema, we call pitting edema, we think circulatory, we think heart, we think kidney. When you have non-pitting edema, it can be from having fluid pitting edema that over time, the proteins have consolidated to some extent. So someone with long-standing edema, it eventually will be non-pitting. But the relatively sudden onset of non-pitting edema, of this solid kind of edema, then you have to think about lymph nodal obstruction, tumors, surgical intervention. Those are the kinds of things. And then you look at this is the big nugget as we do immunology, the kind of cells, the two major types of lymphocytes. Typically, when we look at that peripheral smear in the lab, you will see T cells and you go over the B cells morphing into plasma cells. And we're going to do that again anyway. So it'll help to reinforce immunology. So again, and we'll get into the response that are there and the distinction between T and B cells and why there is such an important distinction, how they work together. Macrophages, the interesting dendritic cells. You remember in the skin, you'll see it in the liver. Any area where you have an opening, so in the skin we come in contact with foreign matter. Certainly gastrointestinally we come in contact. Those are they play an important role as well as sampling the environment that are there. It basically allows us to have sort of like a mini immunological response. The immune system is like any other system in your body. We constantly need to use it to keep it functioning. So it's a lot of use it or lose it. And what we see, because lymphoidal tissue does a lot of straining. We see an abundance in the stroma of reticular cells because those reticular fibers, you remember, they're kind of like collagen, but they're thinner and coated, and they act like a strainer, like a fine sieve or a strainer, or in cooking, a chinois, fine mesh strainer. So here you can see the abundance of fibers that are there, proliferation, we'll get into that, reticular connective tissue. We can find lymphoid cells and reticular fibers all over, okay, because we have a lot of surveillance modalities that are in there. So when we look at true lymphoid follicles or nodules, they're much more tightly packed. B cells can proliferate, etc. We can see isolated areas, particularly gastrointestinally, and what are called Peyer's patches, and the appendix. You'll see the acronym, and you probably heard about it, of MALT or MALT, mucosa-associated lymphoid tissue. In the gut, you have GALT for gut-associated or GI-associated lymph. In the skin, you have SALT, skin-associated lymphoid tissue. So the ALT is the important part. Whatever's in front tells you the location. Primary organs, where we make white blood cells. Bone marrow, where they mature, particularly T cells, in the thymus. Secondary organs, where they encounter, we'll see all of these different types of tissues that are there. They give you a look-see where you can see it. All over the place. Again, that same illustration. Filtration. So, and these are potential places where they become active. And we have to get into the nomenclature. Did you touch on that in immunology, like naive versus activated? No? We'll do it. Okay.
I'd say, yeah.
We'll get it. We'll get it in. It's a naive lymph cell. Okay, and cortex and medulla, it's anatomy. I love that. I see multiple inputs, filters through here, limited outputs. We see that anatomically a lot in the construction to allow things to pass relatively slowly but thoroughly throughout a particular anatomical location. Don't you think that's clever? I do. Here, like, you can see little notches where fluids come in. You see more of that, and they talk about afferent and efferent. That's anatomy. So these are afferent versus efferent. I always have to do this, everybody. You remember I did this in anatomy, but because there are people in here who didn't have me or recently for anatomy. What's an inflamed lymph node? A bubo. Where that name? That's how they got the name for bubonic plague, and that's why you and I call sores boo-boos. I want to do the yogi and the picnic basket and the bear. Oh, boo-boo. Oh, Yogi, the Ranger's not going to like that.
You do a better boo-boo than Yogi, I will say that.
No, thank you. What?
Would you agree with that?
Yeah, I'm not as good at a Yogi.
Yeah.
Not an average beer.
You look her.
Yeah, I know.
You impersonate Haley.
It's impossible. I don't have the hair. Oh, they're going to keep waiting. Bye. See, they like me.
We like you.
Not as much as they like me.
That's not true.
Big difference.
We know you better than they do.
But
Who even are they?
who even are they?
Are you cheating?
Those
on
are
us?
first year. I am cheating on
They're
you.
irrelevant. You'll probably never see them again.
I mean, they're nursing students. I never see them again.
Exactly.
But they're young and impressionable. I'm trying to make a good impression.
Are you calling us old and impressionable?
Yeah, old and unimpressionable. So, named after the chief clinical feature of the disease, metastasis, the spleen, very interesting organ. Again, double duty. Its primary job is filtering the blood. Its secondary job is the lymphatic aspect, because the liver can take over for that. It's got white pulp, and red pulp is for blood filtration and getting rid of old red blood cells. The white pulp is lymphatic. You can see that here. So I'm scrolling through this to show it to you that are there. And again, a lot of times spleens rupture. That's the watchwords with that. So as you can see, and spleens are very regenerative. These are all those associated lymph tissues. And the neat thing about tonsils is these little crypts. So here's fluids and materials we're bringing in that have little openings that kind of act as the entry points for them to be dealt with. And I think that's basically everything. So again, it's mostly anatomy, but I did want to go through it. And so I have a couple of minutes, and before we start the immune system, I wanted to kind of give you my concept of it that's there. And what I know you did, I'm sure anybody at immunology, and I have to do this for the folks who aren't taking it, since that's an elective, is the concept of what to me the immune system is. It's a series of barriers. Okay? It's almost I always think of it in a military context. It's like a series of barriers. It's like having a giant fence that's out there. So you have a mechanical barrier. You and I call it skin or mucosal lining tissue. Then you have a barrier within that barrier that's cellular, mostly in nature, and maybe some chemicals that are associated with it. But you could have guard dogs patrolling. That's what some of those cells are like inside the barrier. If you breach one level, you have another level. But if you are able to breach those innate levels, which are non-specific in nature, and those are the ones we use the most. Okay? Our innate barriers, our skin and lining tissue, all of the things that we're going to go over are what we really employ the most. When we get inside into the second line defense of chemicals and white blood cells and other kinds of cells, they basically can take care of most of it. How many times have you got up and said, boy, I feel a cold coming on, and the next day, it's like, boy, I feel much better. I must have had that 24-hour virus. There is no such thing. It doesn't exist in real life. That was your immune system going, I got you covered, baby. Right. Thank you very much.
It's not really working right now.
And sometimes it doesn't.
Oh, I swear, I don't even have one. It doesn't work ever.
You've got to stop burning the candle at both ends. You got to stop. If you would stop doing all that drinking and partying, you'd be fine.
Oh my God. Just call me out.
You just. And so that's the second line of defense. If you breach those, then, and we don't use it, those are non-specific, generalized defenses for anything that could be considered an invader. It's when we get to the third line, the adaptive defense, that is a vigorous process, whether it's cellularly based or chemically based, read that as antibodies. That's very, very specific. And then we get into the timings. That's the easiest concept for all of this. If you want to think of it, to me, it's a truly physiological system, and it's a system we have to rely on the most. As we get into this, you'll see that now we interact with it much more than we used to. And that's why we're seeing problems. We see more, HIV alerted us to immunological diseases, that in that case, a viral-based disease that caused immunological activity problems, but was not the only disease entity that does that. We see a variety of liver diseases, alcohol-induced liver disease is certainly predominating. Again, the lack of availability of circulating proteins and lack of availability then of circulating antibodies that are protective, gone. So you have, we see more, and now we begin to see, we recognize it. We've started to recognize autoimmune diseases, which are more common than you think, and we have more treatments for this. Not just because we do more transplants, but that's part of it. We recognize, and myself, you will see, I take an agent that combats something called tumor necrosis factor, which is one of the things, and it's an anti-tumor necrosis factor. It's the reason why Monday and Wednesday I had a headache to beat the band, because I try to put off taking that shot because it always gives me a headache. That's kind of where we're heading with this. So I did want to introduce it. It's a functional, read that as physiological system. They're intertwined. If you damage one, the other one ramps up. We have an elegant system of chemical signals that say, if something got through all those defenses, we better bolster the defenses. Okay? Innate defenses are not, both release and recognize many of the same things. They don't have a specific, the innate response releases proteins that alert cells of the adaptive system to foreign molecules. Hey, somebody got through our defenses. So this is, it's a very neat sort of interwoven complex. And why it's so important, it doesn't matter where you're going into a medical or non-medical field, but you deal with it every day. It's part of the thing that people, I think, started to become more aware of vis-a-vis during COVID. We began to learn a lot more about it, because the principal way that COVID hurt people was it caused an immense and untoward immunological response. And in some individuals, the healthier you were was not to your benefit, but where in general it is. It's very interesting. Very, very interesting. So I'll leave it there. Enough of listening to me